I think it's already worth to say good night to everyone. Um, so before I tell you about the studies in our country, I will share what were the reasons behind. Because every time we ask ourselves questions, okay, we have people who suffer because we are underestimated all those who are already HIV positive. But why do we have troubles in this second 95%? Why, like 73% of the people who are aware of their status actually take the ART treatment? So we would like to know who are the people who, knowing their status, do not take treatment. What is their socio-demographic status? What are the reasons behind why they actually don't take the treatment? So what are the factors which could contribute towards improvement of the situation and actually making these people come back to the treatment? So that's why colleagues from our national program and thank them very much for this interaction. And with support of the country office, UNAIDS, and WHO, we managed to implement 3 studies. The first one was a survey among 34 people living with HIV, older than 18, who were not on ART treatment in the last year for longer than 30 days. So the ones who were considered to having abandoned ART treatment, people knowing their status and having started their treatment, but for some reasons who have abandoned their treatment. So we wanted to know who they are: women, men, their age, employed, unemployed, with permanent income or without permanent income. So, having examined their social demographic profile, we understood that this group has no different features either by age or sex compared to the people who are in the treatment program. So neither sex nor age actually are factors to abandon the treatment. When compared or benchmark against the stigma index study, we also realized that even their education level of the abandoned cases is not different from the education status of the people on in the IRT treatment. But actually, half of our respondents, what we noticed, were low educated, so they didn't have higher education. Officially employed of them was 1 in 5 respondents. So only 20% of the people who abandoned their treatment, ART treatment, they were actually had a permanent income. And if compared to the level of employment among the people on ART treatment, they will find it a big percentage at with 32.4%. Another question which we asked ourselves was the reason why they abandon treatment, and we thought that maybe they go abroad because we have a high level of labor migration. But when we actually compare the level of labor migration among the people who abandoned treatment, we actually find that it was quite the same as the level of labor migration among the people on ART treatment. But at the same time, it was quite a high percentage, because both studies actually show that over 25% of the people in the last year left the country for longer than 3 months. Another factor we analyzed was, which we observed actually, that among the urban population of people living with HIV and on ART treatment, so their share was bigger with 30%. Then among those the respondents of our study who abandoned treatment. So we might suppose that availability of the centers can be a factor to uh, um, consistent following of the ART treatment. So another factor we supposed was that the percentage of alcohol users or psychoactive substances users must be significant. So more 50% of our respondents said that they consume alcohol more than 3 times per week. Uh, when we evaluated the key reasons indicated by our respondents, we grouped them into 4 big categories. So the most frequent ones, or the most frequent answers were the answers about availability of healthcare services. Practically half of them, or 47.9%, answered that they didn't have sufficient time to attend the healthcare center. 41% showed that they lacked financial resources. 29% said that it was difficult for them to reach the center because of where they stay. 14% complained about long queues, a waiting time, and 14% also mentioned that they couldn't leave their job place. Then the next category was that about 40% of the people said that they just forget taking pills regularly every day, including because they consume alcohol or psychoactive substances. Number 3, the third category, grouped the answers related to unawareness of the need for such treatment, because 29 almost percent said that they don't see any reason to take this treatment because they feel good or they don't believe the efficiency of such treatment. And the fourth group included the answers of side effects, 22%, or some other related diseases. So when having analyzed the factors mentioned by our respondents and which could actually help them come back to the ART or not abandon ART, then we found that over 65% said that access to medicines for longer times, like for 6 months or 12 months, could contribute for them to stick to the treatment. About 45% said that they wish this treatment be available closer to their residence. 43% believe that if they had their travels to the treatment center paid, that would also be a positive contributor. 24% more would like to spend less time to access medicines. 90.5% actually wish to have better appointments with the doctor. And almost 18% said that they wanted more time for communication with the doctor. What else to improve the quality of treatment? So they wish actually easier schemes of treatment, like once a week or once a month, or maybe once in 6 months or 12 months. 30% said it. And 24% wanted medicines with fewer side effects. The third category had a requirement for treatment of addictions. First of all, alcohol addictions, these are 18%. And 10% actually said that they wished a more friendly attitude from the medical workers. So if I'm to make conclusions and recommendations from this study, then I would say that every person with HIV should initially be considered as a potential candidate to abandon the ART. And given that the key factor here is the availability of such services, we have to keep on decentralizing ART treatment. Another important step towards the improvement of such services would be their integration and making this treatment available closer, and the alcohol treatment to be closer to their places of residence. And also, we should pay more attention to improving communication skills of medical workers. So these have been key conclusions of the first study, which was a survey which we conducted in three localities. One was in the Hospital of Dermatology, the AIDS Center in Tiraspol and AIDS Center in Melt, and it was conducted by both medical workers and peer-to-peer consultants. Another group we focused on were the people who addressed for specialized, who sought specialized medical treatment past more than 3 months after they found out about their diagnosis. In other words, when they received their positive test. So the sample included 150 people living with HIV, older than 18 months, and again, those who started their treatment passed over 3 months after their positive test. Now, some social demographic features. This group was different from the group on ART treatment and those who abandoned the treatment. So, because this group included a high proportion of a high share of men compared to previous studies, and their age, the age of the sample was also higher. The level of education was also higher because more than half of the respondents had either professional, vocational, or higher education. Respondents in this group more frequently said they had a permanent income and a labor migration. Actually, 34% of them said that they abandoned the country for more than 3 months seeking for a job abroad. The urban population is higher in this group, and the consumption of alcohol or drugs is less than in the other group. So the profile is the following: these are men, older men who frequently go abroad for work. So the reasons, if we test them, then 52% of them were tested for HIV, accompanied by some other diseases. 1/4 of them said that they were not informed, they had not been informed that they were taking an HIV test. 13% of them didn't have any information about their positive status, and 15% did not understand that their test was positive. About 1/3 of the respondents didn't know where to seek specialist services. So now about the reasons of this late claim of assistance. Like 40, so we also split them into 4 groups. In the first group, 40% thought that they can always start their treatment later. 32% didn't believe they were infected. 16% didn't know where to look for help, and 14% don't believe HIV exists. Second group, 31% answered that they went abroad for work, and 17% said that they had to be, it's their daily routine, they always have to be at the job place every day. 26% said they felt ashamed, so it's connected with stigma. They felt ashamed. 25% were afraid to open their status, and 10% were afraid of negative attitude from the medical workers. And the last group included the lack of trust towards medical services. So 16% said they just didn't believe in effective treatment. The factors which actually motivated them to look for ART treatment, so 54% of them felt worse, and therefore they asked, and 52% did it on insistence of a medical worker. So one of the conclusions is that we need to better focus on the medical workers to improve their communication skills. Maybe we should also design some promotional content. Well, and our third study looks more like analysis of data rather than a survey. And this is analysis of data about the people who have not reached any treatment in the time interval of more than 6 months. So in 19 we had 9% of such people, and in 2020 it was almost 12%. Having compared to the death database, then we see that 32% of the people, 32 people died actually at the time of study, and we still find 41% of them who never reached the treatment. It's important to design a mechanism to reach out to these people more effectively without breaking their confidential information, but at the same time to attract and to urge them to join the treatment. We should also pay more attention to capacity building of the medical workers. And to design better programs for tests and support. At the time of the study, we had only 3 such centers. Nowadays, we have decentralized the system. We have 23 centers available, and the staff undergoes capacity building trainings, and the situation is improved.
Thank